everyone, and welcome to today's webinar, Key Features of Immune Cells During SARS-CoV2 Infection. I'm Jennifer Woods of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Thermo Fisher Scientific. To learn more, visit thermofisher.com. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Sara De Biasi, Assistant Professor, General Pathology and Immunology, School of Medicine, University of Modena. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Sara, you may now begin your presentation.
Good morning, and thank you for the nice introduction. Today we talk about the key features of immune cells during SARS-CoV2 infection. But before starting, I would like to acknowledge people who donate money to perform this research in this very difficult period. So I would like to thank Glam Glass, San Felice Banca Popolare, Gianni Gibellini and Coffin, Franco Appari, Andrea Lucchi, Biogas Europe Service, Pietrangelo Bertoli Fans Club, Rotary Club, Luca Cicchetti, Paola Paglia, Leonardo Berrettia, and all many people who were helping us with their precious donation. And of course, I would just want to thank my colleagues that during this period helped me in doing this research. And of course, I would like to thank all the clinicians that cure the people in going to infectious disease clinics, Department of Anesthesia and Intensive Care, Respiratory Disease Unit, Department of Laboratory Medicine and Pathology, and Department of Surgery. So this is the outline of the talk. So I would like to start with the introduction. I would like to tell you something about T cells, about cytokine storm, about B lymphocytes and the immunophenotype of B lymphocyte in SARS-CoV2 infection. And I would like to focus on innate immunity, talking about monocytes and in particular immunometabolic paralysis of immune monocytes. And I would like to conclude my talk. So the precise mechanisms triggering the pathogenesis is still poorly known, but two different and often concomitant and interlinked features have been observed. First of all, the abnormal production and utilization of a variety of molecules of innate immunity. And second, the massive activation of cells belonging to the innate and of adaptive immune system. And in several patients, nonetheless, the immune inflammation is really high. The inflammation is not able to clear infection as a normal immune response, leading to several damages to the lungs. And this is our experience. So the first patient was admitted in Modena University Hospital in February 26, 2020, we collected the blood coming from the consecutive admitted in infectious disease clinics in the 21 patient with the symptoms of include sore throat, fever, cough, dyspnea, and chest pain. At the admission, SARS-CoV2 was detected in nasopharyngeal swab specimen by real-time reverse transcriptase PCR. And in all of them, pneumonia was subsequently confirmed by X-rays. All the patients were lymphopenic, so the lymphocyte count was really low if compared to normal values, and the median was more or less 1,000. We wanted to investigate the T-cell phenotype in COVID-19 patient. So we perform a really high parameter T-cell immunophenotype, and we perform clustering analysis. And thanks to this method, we were able to identify all the spectrum of all different subpopulations of T-cell. starting from naive, going through transitional T cells and memory, now activated naive, central memory recently activated, transitional memory, and effector memory. And we were also able to identify different subpopulation of Tregs. But what we find out is that in COVID patients, there were a higher percentage of naive Treg, a higher percentage of effector memory expressing PD-1, effector, and a higher level of central memory Treg, as well as activated central memory T cells. We confirmed this data by doing manual gating, as we were able also to calculate the number of these different subpopulations. So if we didn't see any differences in the macro population of T cells, such as effector memory and transitional effector memory T cells, we were able to find differences in the absolute number of CD4 T cells. All the subpopulation were lower if compared to healthy subject, in particular, and higher if compared with activated effector memory T cell or T cell expressing CD57, which is a marker of senescence, FPD1, which is a marker of activation. We were also able to characterize T cells in COVID-19 patients. So we were able to characterize T cells in terms of Th1, Th2, and Th17 by analyzing the expression of CD161, CCR7, CXCR4, and CCR4, and CXCR3 together with Tibet. And what we find out is that we find higher level of T cell expressing CCR4, higher level of T cell expressing CXCR4, and higher level of and lower level of T cell expressing CCR6. We perform the same on about the CD8 T cells. So on CD8 T cell, we perform the same immunophenotype, and thanks to FlowSum, we were able to clusterize different subpopulation T cell covering the whole spectrum of T cell subpopulation, going from naive, arriving to the terminal effector memory expressing CD57 and CD38 positive receptor. What we find out is that all the activation and the exhaustion marker were higher in patients with COVID-19 if compared to healthy donor. And again, we confirmed this data by doing manual gating, and if we didn't see any difference, and if we confirm the data regarding the percentage of the population of T cell, we were also able to calculate absolute number, and we see that COVID-19 patients were characterized by lower level of CD8, lower level of naive T cell, and lower level of and higher level of activated T cells, such as those expressing HLA-DR and CD38. We were also able to characterize CD8 T cell in terms of Th1, Th2, and Th17 by using the same panel. And also here we find that the COVID patients were characterized by higher level of CXCR4, higher level of CCR4 positive, higher level of GATA3 cells, and higher and lower level of Tibet. Moreover, we find very interesting the fact that this kind of cells, so the one expressing CD161 and CCR6 positive, which among the CD8, which can resemble the mucosal associated invariant T cell population, are lower in the peripheral blood of COVID-19 patient if compared to healthy donor. And this can suggest us that this kind of cell are able to migrate into the lungs and produce cytokines in the lung, sustaining inflammation. We were also able to characterize this kind of all the T cell spectrum with the proliferation index. Then so we can see here that, for example, among CD4 and among CD8, the terminal effector population is able to is characterized by a lower index, a lower proliferation index among CD4 and CD8, and a higher percentage of divided cell are regarding CD8 T cells. So maybe we can explain the fact that the cells are characterized by higher level of CD57 and PD1 because they have proliferated more. We were also able to characterize this cell from a bioenergetics point of view. So we measured the oxygen consumption rate and the extracellular acidification rate among CD4 and CD8, and we didn't see any differences between control and healthy donor. And this is a slide regarding the cytokine storm. So here you can see a lot of cytokines produced by different kind of population of T cells as well as innate immunity cells. And what we can see here is that the COVID patients are characterized by higher level of cytokines, pro-inflammatory cytokines and anti-inflammatory cytokines, suggesting that this kind of COVID patients were characterized by a higher level of production of these cytokines, but this kind of production was not regulated because we found higher level of pro and anti-inflammatory cytokines. For example, we found higher level of IL-8 produced by monocyte, higher level of IL-10 that can be produced by T regulatory cell and Th2 cells, and higher level of galectin-1, galectin-3, and galectin-9, which are molecules produced by monocytes. And if galectin-1 is a pro-resolving inflammation molecules, galectin-3 and galectin-9 are inflammatory molecules. Moreover, we found higher level of TNF-alpha and higher level of interferon gamma, as well as IL-1 alpha and IL-1 beta. And of course, higher level of IL-6 among COVID patients. We were also able, but we wanted to see also which kind of cytokines was able to produce T cells as a population. So we performed this flow cytometric panel to evaluate the expression of cells producing TNF-alpha, interferon gamma, IL-17, IL-2, and CD-granzyme B and CD107A. And we find out that COVID patients were characterized as well in CD4 and as well as in CD8 with a higher percentage of cell producing interferon gamma, TNF-alpha, IL-17, CD107A in CD4 and in CD8 positive T cells. Moreover, we were able also to quantify the polyfunctional response of T cells after in vitro stimulation, and we see here that COVID patients were characterized by higher level of polyfunctional cells among CD4, and in particular they were characterized by higher level of IL-2 and IL-17 production. So with this first part of the talk, we can state that SARS-CoV2 creates a dramatically confused immune response. Indeed, in COVID-19 patients with pneumonia, we have found the presence of increased T-cell exhaustion, activation and senescence, altered differentiation of different T-cell subtypes, high plasma level of a variety of cytokines, from those with pro-inflammatory action to those that are able to inhibit the immune response or that are related to Th1, Th2, and Th17 phenotype. And we found a massive in vitro production of several cytokines with a potential skewing of activated cells towards Th17 phenotype. In the meanwhile, we were also able to characterize B-cell phenotype, and what we find out is that doing a polychromatic flow cytometry panel investigating the spectrum of all B-cell, we find out that plasmablasts increase in COVID-19 patients. So with the same methods, so with using an unsupervised method, we were able to investigate the spectrum of all B cells. And in particular, we found that all COVID patients were characterized by higher level of different subpopulation of B cells, such as transitional, memory, IgM only, surface B cell, memory unswitched, IgM negative plasmablast, and we were also able to characterize a population of unswitched CD24 positive B cells characterized by the expression of CD24 and the lack of expression of CD21, resembling a population of senescent B cells. We perform also PCA, so principal component analysis, to investigate which kind of variation was affected more the COVID-19 patients. And what we find out here is that, for example, patients with the higher level of plasmablasts and higher level of naive B cell and higher level of memory unswitched cell were able to be discharged from the hospital if compared to those who were characterized by higher level of D-dimer, higher level of SOFA score, higher level of CRP that were death. So the main findings regarding the B cell was that the global alteration in the B cell compartment that underlined the immune system effort to make up lymphopenia with the increase in transitional B cell and plasmablast. Memory B cells that are supposed to remain stable or slightly increase from 20 to 80 years in our patient were significantly lower than those of control who were younger. The increased presence of plasmablasts in patients suggests that the involvement of innate B cells in production of antibodies, along with the findings that in few cases IgG but not IgM were present in the plasma of recently infected patients. Through PCA, we could identify the factors that are important in moving the balance towards discharge or death of the patient. And the window of opportunity represents the moment in which a therapy like the one that blocks ISAC pathway can be used. And last, I would like to talk about monocyte compartments of COVID-19 patients. Inflammation is triggered and regulated by cell-like monocytes, who are the second population who acts during inflammation. This kind of cell are MHC class II molecules, and they can be distinguished into three different subsets: classical monocytes, intermediate monocytes, and non-classical monocytes. All of them characterized by different expression of CD14 and CD16. All of these populations rely on both oxidative phosphorylation and glycolysis for ATP production, but no one investigated how SARS-CoV2 infection could impact monocyte metabolism and function. We did that, and we find out that monocytes of COVID patients were characterized by a lower oxygen consumption rate, a lower ATP link, a lower maximal respiratory capacity, a lower proton leak, and a lower oxidative burst, and a lower BASAC-EGAR, showing that this kind of monocytes were metabolically exhausted. And in particular, calculating the area under the curve, we were able to see the ability to maintain the maximal respiration and the ability to maintain the maximal oxidative burst. And this kind of maximal respiration and oxidative burst was lower in a patient within a COVID patient if compared to healthy subject. Given the fact that mitochondria is the powerhouse of the cells, and the oxidative phosphorylation happen in mitochondria, we would like to have a look at mitochondria by doing transmission electron microscopy images. And what we find out is that mitochondria from COVID patients were different in terms of dimension. They were characterized by a higher heterogeneity in shape, and in particular, even if we found that the membrane of mitochondria was fine, was okay, the inside part, the inside part display a higher degree of swelling. And in particular, we found changes in the aspect ratio and in particular in the roundness. We wanted to characterize mitochondria by analyzing the mitochondrial mass by using mitotracherin and mitochondrial membrane potential by using JC1. And what we find out is that mitochondrial mass was higher in patient with COVID-19 patient, and the mitochondrial membrane potential, the percentage of depolarized mitochondria was higher in COVID-19 patient if compared to healthy subjects. We wanted to investigate also the landscape of monocyte phenotype in COVID-19 patients, and we follow the same approach we did for the other two studies. And so we were able to identify classical monocyte, intermediate monocyte expressing CCR2, and intermediate monocyte not expressing CCR2, and not classical monocyte. And what we find out is that we found that COVID patients were characterized by higher level of intermediate CCR2 expressing T cells, higher level of intermediate not expressing CCR2, a lower level of classical, and a similar level of non-classical monocytes. We wanted to confirm also this by doing manual gating, so we were able to identify CD14 on the basis of the expression of CD14 and CD16, three different subpopulation of monocytes, so the classical expressing CD14 and lower level of CD16, the intermediate expressing higher level of CD14 and higher level of CD16, and the non-classical monocyte, the one expressing low level of CD14 and higher level of CD16. And in this population, we wanted to analyze exhaustion markers such as PD-L1 and TIM3. We confirmed by manual gating that COVID patients were characterized by lower level of classical monocyte, higher level of intermediate monocyte, and unchanged level of non-classical monocytes. And regarding the expression level of PD-1 and PD-L1, so the exhaustion marker, we found that this marker was higher in COVID-19 patient if compared to healthy donors in all the different subpopulation of monocytes. So this kind of cells were metabolically exhausted, but also express also higher level of exhaustion markers such as PD-1 and PD-L1. Given the metabolic exhaustion, we wanted to investigate also the in vitro cytokine production by monocyte in COVID-19 patients. So we stimulated monocyte with PMA ionomycin, and we analyzed the expression of TNF-alpha and interferon gamma. And what we find out is that even if patients were characterized by metabolically exhausted monocytes, the cytokine production was unchanged after in vitro stimulation. So these cells were still able to produce cytokine as well as healthy subject. But we wanted to investigate also plasma level of cytokines and chemokines involved in monocytes regulation. And also here we found that the COVID-19 patient were characterized by higher level of pro-inflammatory cytokines such as IS6, TNF, interferon gamma, IL-18, PD-L1, and higher level also of GM-CSF, OPN, and CXCL10. And given the fact that we found higher level of GM-CSF in the plasma of COVID patient, we wanted also to investigate the presence of immature monocytes in COVID-19 patient peripheral blood. And by doing a flow cytometric panel based on the expression of HLA-DR, CD14 and CD13, we were able to identify, and CD64, we were able to identify immature monocytes monocytes and mature monocytes. So immature monocytes were not expressing CD13 and CD14 and CD64, and mature monocytes were those expressing all of these three markers. And we find out that in peripheral blood of COVID-19 patients, there are a higher percentage of immature monocytes if compared to healthy subjects. So if we want to conclude, we found that unaltered bioenergetics and mitochondrial expansion of monocyte in patients with COVID-19 pneumonia, and this kind of altered bioenergetics and mitochondrial expansion resembled the one that someone found in sepsis, in which monocytes are characterized by immunometabolic paralysis. So here we find that dysfunctional monocyte with decreased respiratory burst, increased expression of inhibitory checkpoints, abnormal mitochondria with low membrane potential, and decreased OXPHOS and unchanged cytokine production, with a completely different landscape of monocytes, including the presence of immature monocytes among peripheral blood of COVID-19 patients. So if you want to wrap up, the immune system of COVID-19 patient is dysregulating, and it is characterized by marked T cell activation, senescence, exhaustion, and skewing toward Th17, expansion of plasmablast and loss of memory B cells in peripheral blood, and metabolic exhausted monocyte and different distribution of monocytes subpopulation. And having said that, I would like to tell you to wear the mask. And thank you for your attention.
Thank you, Sara, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for today. Okay, let's get started. Our first question is, could it be concluded that there is an immunological consensus signature among all COVID-19 patients?
Oh, thank you very much for this question, because this question gives me the opportunity to wrap up what has been found in the last month in COVID-19 research. So first of all, I would like to start with the cytokine storm, because we found the plasma of the patient a lot of pro-inflammatory and anti-inflammatory cytokines. So it seems that the immune system of the COVID patients is kind of like to react in a desperate attempt to respond to viral infection in a very unorganized way. For instance, we found high level of pro-inflammatory cytokines such as galectin-1, IL-6, IL-8, TNF-alpha, but also higher level of anti-inflammatory cytokines such as IL-4, IL-10, TGF-beta, and CM-CSF. So this kind of concentration reflect a disparate attempt of the immune system to answer to this kind of infection, even if the pro-inflammatory status is anyway predominant in the plasma level of this patient. Second of all, I would like to say to underline that we found a dysregulation in monocytes, because we found a higher level of pro-inflammatory cytokines produced by monocytes, and the presence of immature monocytes in blood due to probably high level of GM-CSF. And monocytes are characterized by dysfunctional metabolism in terms of respiration and glycolysis. Mitochondria are depolarized, bigger, but characterized by morphological swelling. So we didn't find any kind of changes in terms of cytokine production after PMA ionomycin. Third, we found a dysregulation in T cells. So we found higher level of activation of T cells in terms of expression of CD38, HLA-DR, expression of PD-1 and CD57. And we found that this kind of cell were able to proliferate more, and in particular in the effector compartment, that could explain the higher level of CD57. Moreover, we found higher level of Th1 cytokine and Th17 cytokine produced by both CD4 and CD8. And fourth, we found dysregulation in all B cell compartments. B cells are very important for the production of antibodies, and we found very higher percentages of plasmablasts, a decrease of naive B cells compartment, even if the patient were older than the healthy subject, an increase of transitional B cell and a decrease of memory switch and unswitch B cells. And we did not find changes in B cell proliferation. So overall, we found a lot of dysregulation in the immune system of COVID-19 patients.
Okay, thank you, Sara. We have another question.
Yeah.
What are the weakest points of viral infection progression that can become therapeutically relevant with intervention on the immune response?
This is a very interesting question, because I think that the crucial point is the immune response given by the innate immune response, because of course it's the first one that is able to produce cytokines. For instance, neutrophils and monocytes are able to migrate into the inflamed tissue and are able to produce pro-inflammatory cytokines and give origin to this kind of so-called cytokine storms. So I think that calming the cytokine storms through the immune modulation is one of the current managements of COVID-19 patients, by using, for example, tocilizumab, that is able to block IL-6 receptor, or by using corticosteroids. And then there is another point that are the adaptive immune response that is able to mount the immune response, and these kind of cells are able to continue to produce inflammatory cytokines and recruit other immune player in the site of infection. So I think that the immune modulation is the best current management that could be applied by now.
Thank you, Sara. I have another question. The increase in the expression of PD-L1 on monocytes and the increase of intermediate monocytes in COVID-19 patients is very interesting. What was the gating strategy for identifying PD-L1 positive cells and CD16 positive cells?
Oh, thank you for the question, because I have the chance to clear our type of analysis. So we perform two kinds of, we perform a 10 colors panel, flow cytometry, to analyze the expression of different markers in different population of monocytes. We analyze the expression of CR2, PD-1, PD-L1, TIM3, and CD38, and CXCR3. And we apply two different methods to perform this kind of analysis. So the first one was the unsupervised analysis. So for the unsupervised analysis, we use flowsome clustering, and then flowsome was run, and we were very careful with the cofactor and with everything that could be carried in the analysis. And then we confirmed this kind of analysis with a manual gating strategy based on the fluorescence Venus 1 control. So we established the positivity and the negativity for all the markers by using this kind of control. So in our panel, HLA-DR were present. So we selected the HLA-DR positive and dim, and CD15 positive. And then in this population, we selected the population expressing CD14 and CD16. And in this population, we analyzed the expression of different markers, such as also PD-L1. We tried different antibodies for PD-L1 because we had some kind of issue with the stainings and with the specificity of the antibody. And at the end, we chose a clone from Thermo Fisher, which is the MAH1 by Thermo, and we were happy with that. And we were able to analyze the percentage of cell expressing this marker, and also the median fluorescence intensity.
Thank you. We have another question.
Yes.
Are any of these patients treated with any antiviral or anti-immune drugs?
No, the patient include in this kind of studies, so studies in T cells, B cells, and monocyte, were all patients without any kind of treatment, because we selected patient at time 0, so we had the blood before they started any kind of therapy. Patients here in Modena are treated with different therapies, such as tocilizumab or corticosteroids, but we were able to take the blood before the administration of this these drugs. So in this kind of data, we show only what happened with COVID infection without any kind of interference by drugs.
Okay, thank you. Next question. Any differences in immune profile in like older patients versus younger patients?
Oh, we are, thank you for this question. We are still analyzing data obtained with different methods. We are still analyzing this kind of patients with this kind of data. And we were able to analyze COVID over 70 and the COVID-infected person under 60. And we found some kind of differences in the main subpopulation of T cells and the main subpopulation of B cells. But of course, we are still analyzing these kind of patients, so I cannot say more because I have to validate everything. But yes, there are differences. On the basis of the age, there are differences in terms of different subpopulation. For example, of T cells, mainly they are the main that we can observe during the natural course of life. So a decrease of naive T cell and an increase of effector memory population. But yes, we can see a difference.
Okay, thank you. We have one more question. What is the predominant finding in COVID-19, immunosuppression or immunoactivation?
This is a very interesting question. I think that this kind of question I can ask taking as example sepsis disease, because in sepsis disease we have two kind of phases. So the hyperreactive phase and the hyporeactive phase that is followed by the hyperreactive phase. And I think that in COVID-19 it is something. I mean, can happen something very similar, because at the beginning we have this kind of cytokine storm, so we can speculate that this kind of immune system is very, very triggered by the infection, and at some point there are some kind of dysregulation and exhaustion that take place because, of course, T cell express higher level of PD-1 and CD57. So I think that on the basis of when we take the blood and in which kind of part of the disease, maybe we can talk about immune hyperactivation or immune deregulation. But I think that there is some kind of similarities with the sepsis disease.
Well, thank you again, Sara, for your time today and for your important research. We would also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.